recording? Thank you so much. Well, welcome everyone. Glad to have you here. This is PEPI, or Project Echo for Primary Immune Disorders. I'm Nick Ryder, faculty at Virginia Tech Carilion School of Medicine, and one of the co-leads for our group. As you see our team here, Angie Tyree, who is our fearless leader in coordinating all events, Dr. Lawrence, Dr. Borish, colleagues at UVA, and Jacob Blakovich, who is a PhD student in the Virginia Tech Translational Medicine, Biology, and Health program. Jacob is a second-year PhD student who is going to be actually leading not only this talk, but the next two. And we wanted to share these dates with you so you could keep them on their calendar. Today, Jacob would be talking about rural health in general in the United States, disparities and opportunities for care, and then talking on the 17th about an overview of what we know currently about rural health disparities amongst patients with allergic and immunologic disorders. He'll then wrap up his three-part series on October 8th, really focusing on what we know about primary immune deficiency patients and rural health. So again, really grateful to have you all here. If you wouldn't mind putting your name, and it's safe for you to do so. I know some of our participants are in a car or maybe commuting, so we don't want you to have any safety events, but if it's convenient for you, please put your name and your affiliation into the chat. And with that, I'm going to turn things over to Jacob and thank him for his time. We'll have a time for Q&A after his talk, and we typically reserve the last 3 to 5 minutes for the Q&A. Take it away, Jacob. And again, thank you to all for joining.
All right. Thank you very much for the introduction, Dr. Ryder. I'm going to go ahead and switch my screen over to my presentation here. But as Dr. Ryder so graciously said, I am a second-year PhD student working in his lab, which is the Computational Human Immunology Lab and Innovation Hub. And today I'll be presenting on rural health in the United States, disparities and opportunities for care improvement. Just as a quick disclaimer, I'm probably going to talk pretty fast because I have a lot of material in this presentation. I will leave as much time for questions as I can at the end, but feel free to email me with anything else you may have to ask. So just to start, we'll talk a little bit about what is rural. So rural counties are going to be, first we'll talk about urban counties, which are going to be metropolitan or core counties with one or more large urban areas, including surrounding counties with over 25% of commuters, and then micropolitan, which is your first of the rural type areas, or non-metropolitan, still have an urban area with more than 10,000 people, but they're not as big, or there aren't as many compared to metropolitan areas. And that's once again including the surrounding counties as well. Non-core is anything that isn't micropolitan, essentially. So it's going to be a lot of our smaller counties, those that don't have enough commuters nearby. And if you see the chart of the United States on the right here, you can see that there is some further split of the larger metropolitan areas. But just for our purposes, we'll do rural versus urban or metro versus non-metro. But most of the landmass of the United States is considered a rural area. You can see a lot of dark blue across the map here, and about 20% of our US population lives in those areas. So just as an overall start here, we'll start with disparities in mortality. This is a great kind of map looking at a lot of the things that contribute to the increases in mortality and a lot of the disparities in general that we see in rural areas. This in particular is for oncology, but you can see a lot of the things here like socioeconomic status, health literacy, health insurance, transportation, access to specialty providers, transportation to care, and sometimes the availability of things like clinical trials or certain medications just aren't things you can access in rural areas. And a lot of that contributes overall to disparities in mortality and survival. And here is just an overall view of a map of the United States comparing 1999 to 2003 to 2011 to 2015, looking at all causes of mortality. And you can see that it's gotten a lot better, but there's still a huge chunk kind of in the bottom right-hand corner of the United States, in the South and Southeast, in Appalachia, and in Alaska. You're seeing a lot of disparities in mortality still here. There's a lot more, and we're going to go into some of the reasons for that, one of which is racial and ethnic disparities. Looking at a map here once again, which I have a whole lot of in this presentation. In the bottom right-hand corner here, you can see that there's a lot of non-Hispanic Black population in this bottom right corner that we kind of saw was where one of those big mortality areas, as well as a lot of Hispanic population sort of over here in Texas in the south, and the American Indian Alaskan Native population, a lot of which is in Alaska, which makes a whole lot of sense. And then you can see across a lot of the other rural areas in the United States, they're over 80% white. So it's important to consider not only our minorities, but also there's going to be some disparities for white individuals as well across this. But for the most part in this presentation, we'll kind of focus on this bottom right-hand corner that we'll see across a lot of our maps. So moving from there, here's a comparison between non-Hispanic Black and non-Hispanic white, just overall mortality rates from 2012 to 2015. You can see highlighted here are rural areas at the bottom, and you can see generally those numbers are higher than our overall US, which is the last number here, and higher than a lot of our metropolitan areas as well across all of these categories, which is multiple age groups. And for the most part, those disparities are higher in the non-Hispanic Black populations than the non-Hispanic white. There are a few categories, especially in the older individuals, where some of the non-Hispanic white populations do have a higher mortality rate in some of the rural areas here. There's also a comparison here on the right, which is the same study, but stratified by race instead. So it's looking specifically at that. You can see that the AIAN population is the highest overall for all causes of mortality per 100,000 individuals. And specifically, that's in our non-core or our very small rural areas. And you can see across the board, our highest numbers are going to be, for the most part, in those smaller rural areas compared to others. There's also a few Black population ones, as well as the chronic lower respiratory disease for the white population. But across the board, you can definitely see, a lot of differences between your rural and urban populations for all races. And then here's a chart which is kind of going to lead us into our next slide, but it's looking at individuals who have had 2 or more ER visits in the past 12 months. You can see there's certainly some racial disparity up here at the top, where the AIN population is going to be attending a lot more often, as well as Black and multiple race and Hispanic. Those are kind of our higher categories here. But one of the things we're really going to focus in on this one is that you can see generally there's going to be more visits for individuals who have lower education levels and are more impoverished. And that's going to lead us into our next part here, which is socioeconomic status. Starting with education, looking at the percent of the US population with a college degree and its change over time, you can see that it's pretty similar to how it was from 2000 to 2015. As far as education, there are a few spots where it might even be a little bit worse, especially in Alaska here. But once again, kind of seeing the southeast states through Appalachia, you're seeing a lot of those disparities in overall education. And that's going to lead to some amount of disparity in health literacy that we'll talk about later, which also connects us to poverty. This is a study looking at high school education and poverty rate. The black outlines around states you're going to see are states with poverty rates or counties with poverty rates of 20% or higher. And your more yellow, orange type colors are going to be places where there is a higher proportion of individuals with less education. And you can really see a correlation a lot of the time here with poverty and education, which is something we know pretty well. But you can see a lot of that down here in the bottom right-hand corner of the United States once again. And then this is a study just from census data. Just another way to look at this here, you can see the darker colored blues are counties where there's a greater proportion of individuals who are impoverished. Once again, you can really see a lot of that up in the Appalachian region in West Virginia and down in the South, where you're seeing a lot of those rural areas in poverty as well. Past that, we're looking at employment, and I think this is a particularly interesting figure when you think of it in comparison to the other maps that we've looked at. You see that there's a lot of unemployment in Alaska and down in this southeast corner of the United States, but there's also a lot of it over on the West Coast. And I think that's particularly interesting because we saw there wasn't a whole lot of poverty over on the West Coast. So that's a place where we can certainly consider implications for public policy and things. Maybe they have better social support programs or ways to help those individuals who are unemployed not be impoverished, as we see down in this southeast portion of the United States. So it's certainly something to consider and somewhere we could potentially work on improving. We'll also look into healthcare access, starting with health insurance. This kind of connects us to our last slide, seeing poverty, unemployment, and insurance rates across the board, stratified by race. You can see that for the most part, the uninsurance rate is highest in the AIAN and Hispanic populations, with poverty highest in the African American, AIAN, and Hispanic populations as well. However, it's nice to note here that the uninsurance rate for the African American population is substantially lower when compared to the other kind of highest categories for poverty. So obviously we need to do a little more outreach and things like that to try to improve insurance and care access, especially for the AIN and Hispanic populations, and maybe make some changes in policy to help assist with that as well. As far as access to care, this is kind of a very telling figure. This is total physicians per 10,000 people across the United States. Your darker colors are going to be areas where you have a greater proportion of physicians per those people. And across the board, there's about 35 per 10,000 for metropolitan areas and about 13 per 10,000 for non-metropolitan or rural areas. But pretty much everywhere in the United States, there's a lot of light blue. Obviously, there's a need for physicians just about everywhere, but certainly a greater need to try and spread them out as best we can, because I can imagine it's really hard for areas who have just a few physicians to see that many patients. And that's particularly telling for the next figure, which is specifically primary care physicians per 10,000 people. And here you're seeing pretty much everywhere is light blue. You're seeing very few providers per capita as far as the 10,000 individuals in their catchment area, and on average 8 providers per 10,000 for urban areas and 5 per 10,000 for rural areas. So we obviously need to do a better job of getting primary care providers everywhere for the most part, but especially improving that in rural areas. There's a lot of gaps across the United States you can see here. So certainly could be important for policy as far as maybe finding ways to subsidize primary care providers, moving to non-metropolitan areas, or improving rates of individuals choosing that specialty in other ways. We'll also look at telehealth and internet access, which is especially important for rural care, because a lot of the ways that we talk about improving ways to capture patients in rural areas is via telehealth and internet access and things like that. But something that's really important to look at here is you can see that a lot of these individuals just don't have access to that. You can see that almost 50% of individuals in non-metro areas don't have access to high-speed internet. About a third don't have access to a smartphone with data, and about a quarter don't have access to anything, essentially, as far as that goes. You can also see that this is higher in certain ethnic groups, those who are uninsured and those who are impoverished. But this is a particularly important figure because we're missing at least a quarter, but up to half of these individuals with our telehealth initiatives and things like that, trying to reach these patients. But to some extent, we're going to fail at that. However, I know there have been a lot of improvements after COVID as far as trying to improve digital access and things like that. I wasn't able to find any studies looking at that because the newer years of census data aren't quite as available yet. However, hopefully over the next couple of years, we'll see these numbers greatly improve. Additionally, we'll look at detrimental health behaviors contributing to rural health disparities, one of which is obesity and physical activity. This was a study looking at fruit and vegetable intake, physical activity, and BMI, comparing urban and rural populations. And I thought it was interesting that the urban population generally has a higher rate of obesity and a higher rate of normal weight, whereas the rural population generally has a greater amount of overweight individuals. Partly, it looks like that's because there is a greater amount of physical activity generally in rural areas. Some of that could be due to, just the type of jobs they're working, agriculture, blue collar, just generally more labor intensive jobs where they're going to see more physical activity, or the fact that things are further away and they just have to travel or do more work to get places can certainly contribute as well. However, this is an interesting figure, especially taken into account with some of the other things we'll look at. This is just chronic conditions overall, looking at 2015. You can see here that heart disease and diabetes are pretty similar as the populations they're affecting. You can see that it's higher in men, in some ethnic groups, in those who are divorced or widowed a lot of the time, and generally in rural areas. Once again, you can see that the mortality rate here is typically higher. You can also see that for those populations, it's higher in individuals who are less educated, more impoverished. And at the bottom, you might not be able to read it, but it says not employed, but has worked previously. So to some extent, that's probably a large proportion, the retired population, or older individuals who were able to work previously but don't work now. So it makes sense why that's kind of the highest across the board a lot of the time for these categories. And then cancer in particular is interesting because you're seeing a lot of differences here. It's still higher in your rural areas, but you're seeing more prevalence of that in individuals who are more educated and make more money versus your other contributors here. To some extent, that's probably because those individuals are generally living longer comparatively and maybe not dying of heart disease and things as early. So obviously, that's an important difference to look into as well. There could be other contributors here. Past that, here's a map just looking at diabetes across the United States. Once again, you're seeing kind of that bottom right-hand corner of the United States being our problem child. Down in Sweet Tea Central, we've got a lot of diabetes. And that's just something that you're going to see a lot there because of the culture and things that are important to those people. There's a lot of, food events as gatherings and things like that. So it's somewhere that's going to be difficult to improve, but certainly still a space that we need to work on, improving policy, improving community outreach, and ways to talk to those patients to try to improve their outcomes there. Looking at behavioral health, this was a study looking at barriers to mental health care for rural African Americans, though it kind of applies to all rural Americans in general for the most part. Looking at mental health literacy as a problem, community stigma, systematic barriers, and social support. So obviously with the troubles with education down in the bottom right-hand corner, especially where the non-Hispanic Black population is disproportionately residing in the United States, as we saw on our previous figures. Community stigma, there's a lot of issues as far as people thinking, you're weak if you have mental health issues, you're crazy or dangerous. And a lot of those types of quotes were in that study, looking at why people tended to not seek care for those types of things in rural areas, as well as some systematic barriers and lack of social support, once again, kind of similar to community stigma. This was a study specifically on veterans in these areas, a little bit different, but this was an interesting one as well. You can see that generally the suicide death rate for veterans has increased over time. It's pretty substantial. Most of the numbers we're going to look at are over here on the right as our totals, but you can see that the overall number is higher for urban areas, but the actual proportion of veterans in the study was higher for rural areas, about 33.3%. So right about a third of the individuals in the study. You can also see that it's higher in your kind of younger age group and middle age individuals. It's higher in men, in divorced individuals, and in non-Hispanic white individuals. You can also see that it's very high in the homeless population, which is something that's important, as well as in those who have been in combat, who are more disabled, have a higher burden of physical or mental illness. There's obviously a great need to improve, social support for veterans who need help with mental health care and homelessness, because you're seeing 76, 77% of those individuals in the study committing suicide, which is pretty terrible. So obviously that's an area that we need to work on in the future. Something else that's pretty big in rural areas is the opioid epidemic and drug overdoses. You can see, especially for Virginia and North Carolina, which is kind of right around where we're located, is where the rural rates are generally higher than the urban rates. But there is a lot of space across the United States where the urban rate is higher than rural. So, it's important to remember that while we're interested in rural health and focused on that policy, we need to kind of work on improving everything across the board. But it certainly helps to take it in manageable chunks and not just try to help everybody all at once, because that doesn't work a lot of the time. Further looking at health literacy, this was a very interesting study that looked at office visits and how much information the patients actually got out of the visit. You can see that 40 to 80% of the information they got from their provider was forgotten immediately after the visit. However, it's important to realize that those who used visual aids were substantially more likely to remember that information. They recalled about 80% of the information for patients who got posters or infographics or just written instructions in some way that was easier for them to read, easier for them to continue to look at. And whereas the spoken instructions, you only remembered about 14% of that. So that's certainly something that wouldn't be terribly difficult to incorporate into practice, but could really help with health literacy, especially in rural areas where they might not understand a lot of that terminology. Having the chance to take something home and look it up or just have it presented in an easier way is very helpful for those populations. And this is kind of just a model that that study used, looking how understanding and recall of information contribute to patient satisfaction, which contributes to your overall adherence to treatment, medications, all that kind of stuff. And then this is a quote from a qualitative study looking generally kind of at the culture of rural individuals, talking about physicians, their perspectives on barriers to care, that kind of stuff. And this individual described, a Montana range patient who had a sense of being strong and independent, doesn't really seek out a lot of medical care, take medications. They're really feel that they're strong and independent on their own and don't want to go seek care, or if they do seek care, are going to have a lot more trouble getting them to adhere to medications. And that's one of those points where, trying to improve education and really get to know your patients, incorporate shared decision making and, have a cultural awareness of what that community is like can really help get through to some of those patients. But we'll talk a little bit later more about that barriers to care study as well. Then this was a study looking at the difference in survival for a group of individuals with heart disease, those who had inadequate or marginal health literacy compared to those who were considered to have adequate health literacy, were about 20% less likely to survive over the course of about 2 years, which is a very stark difference. Obviously it's hard to educate patients, but if there's anything that can be done to help with that, it would certainly help to bring those lines together and assist with that survival regardless overall. Then looking at social support for rural areas, this was a study looking at a variety of different services that individuals could access. Just overall, you can see white and Black individuals were less likely to receive any service than other racial groups. Those living alone or those with financial need were also less likely to receive social support services. It's interesting to see that those living in mostly rural counties were 2.5 times more likely to receive any sort of social support than those living in completely rural, whereas urban counties were only about 2 times more likely to receive those. So certainly some work to do on both fronts. Something that certainly could have skewed that, as you see over here on the right, is that individuals living in mostly rural areas were about 25 times more likely to receive fresh food services than those living in other areas. So it's certainly a area where that could have contributed to the mostly rural one being a little higher. This is a little more of that study. Once again, we're going to focus kind of on rural versus urban here. You can see that there's actually better information and referral and better income care social support for the completely rural group versus the mostly rural and mostly urban group. But you can see at the bottom, utilities and transportation were more available for those in the mostly rural and completely rural groups. So certainly some differences across the board as far as what things are available and what things we could focus on to improve in the future. It looks like we need some more help as far as food services in urban areas, but we could use some more help with your utility and transportation type things for rural areas, especially for older rural residents who, a lot of the times can't drive or don't have family nearby, but everything is so spread out in those areas, there can be a lot of issues with them getting access to care. Then this is the barriers to care study that I mentioned. Obviously, you guys are probably all pretty familiar with most of these, but there's a lack of time and a lack of providers generally. There's definitely issues with resources, as we saw earlier in the graph. There's very few primary care physicians per 10,000 individuals in the US. There's obviously some trouble. I've mentioned a lot how improving education and health literacy could really help these populations, but it's hard when you don't have time and you have to choose, do I want to educate this patient more and not have time to see as many patients or not be able to give as good care to other patients? And there's a lot of stuff you really have to balance there, which is difficult to do, especially with lack of support from administration and things like that. This was a quote talking about how a lot of the administrators kind of just see patients as a number, and they want to get as much revenue from individual patients or have you see more patients versus actually concerning with quality of care and things like that. So certainly some systematic barriers that we need help with. That's a place where health policy could really help a lot. It's hard to get through to a healthcare system as an individual, but if you come from a big organization or somewhere else, there's a lot more you can do that way. Additionally, communication is always an issue. Electronic health record is one of the big issues. You have so many different ones. You often don't get notes across, or they come in weird formats, and there's things that you just can't get your patient's information that well. Or sometimes even within the same system, notes don't come across. There's different health record systems and lots of trouble with that as well. But overall, that kind of brings me to a little call to action here I have at the end of I've talked a lot about what the disparities are and places where we could improve health policy. And here's some opportunities for primary care clinicians or others to get involved in improving some of that health policy for those individuals. Obviously, not everyone can commit to a fellowship like these on the left, but those of you who can, that's awesome. But if not, there's tons of organizations, both local and national, that you can get involved in to help, even serve as an expert in your area, say, represent for your patients. What are the issues that you have? What things could you help improve? What things could the organization help prove for those individuals? And if no one goes to talk to those organizations, no one will ever know what the problems your patients are facing are and be able to help. So definitely something that is important, and I am happy to provide more information for anyone that's interested in. But that brings me to the end of my presentation. My email is at the bottom if you have any questions, and here are QR codes for both our PEPI website and our YouTube link for any information you want to see. And anyone who has questions, I'm happy to take those.
Wonderful job, Jacob. This was fantastic. Any questions from the audience? So I'll just raise, I guess, I just want to underscore that PEPI exists to support primary care clinicians who are potentially interacting with patients with primary immune disorders, but either aware of that, but struggling to have services for these patients, or or maybe unaware. So I don't know, Jacob, if you had any thoughts. Clearly, you outlined wonderfully the multifaceted challenges that exist for patients in general in rural America, let alone if they have a rare disease or even a medical complexity more than you outlined, including diabetes, which is not trivial and already a challenge. So towards that, any thoughts on maybe the top one or two areas where we can engage? Anything else you wanted to underscore that's relevant to PEPI? And I know that you're going to be speaking more to this in the next two sessions, but just wanted to give you an opportunity to answer that.
Sure. Thank you for the question. As far as specific areas relating to PEPI, something I'll cover in my third presentation in the series is there are huge gaps in knowledge for anything primary immunodeficiency. A lot of rare disease type things, just aren't assessed in rural spaces because it's really hard to get to that. Some of that's because of the barriers and issues with electronic health record and things like that. We just don't have a good way to look at a lot of those patients. Outside of that, there's certainly some disparities in allergy and immunology, especially in asthma and things like that, that I'll talk about in my next presentation. Um, yeah.
That's great. Thank you, Jacob. Really excellent information. Certainly a huge challenge needing a team to address, but yeah, we want to be part of that solution.
All right, if no one else has any questions, I'm going to wrap it up for everyone. Um, Jacob, that was a great talk. Thank you so much. And Mary also added what a great job you did in the chat box. But with his questions slide, there is a PEPI website QR code and a YouTube QR code. And then also in the chat box, I have our YouTube channel, our discussion board, and our email. So reach out to us if you have any topics that you want us to cover. Because like Nick said, we're here to help you guys. We want us to be able to form a better way so we can all give the best patient care. Just reach out to us and we'll be happy to help you in any way that we can. And we will see you on our next session. Thank you
Thanks,
guys and have a
everyone.
wonderful day.
Bye, everyone.